Good afternoon, everyone. My name is Nirav Shah, and I'm the director of the State of Maine's Center for Disease Control and Prevention. I'm delighted to be able to join everyone this afternoon to provide an update on where we stand with respect to COVID-19 across the state of Maine for today, Friday, November 20th, 2020. I begin today's discussion on yet another sad note. Maine CDC is aware of the deaths of 2 additional individuals who have passed away with COVID-19. One was a man in his 80s from Androscoggin County. The other was a woman in her 70s from Somerset County. Their passings mark the 172nd and 173rd deaths associated with COVID-19 in Maine. These are 2 additional individuals who this year will not be able to celebrate Thanksgiving with their loved ones. We offer their friends, families, and communities our deepest condolences during this time of grief. Their deaths were among the 1,962 individuals who died with COVID-19 in the United States just yesterday alone. And their deaths came on a day when the United States itself logged 187,000 new cases of COVID-19. And their deaths came at a time when over 80,000 people across the United States are currently hospitalized. 80,000 people. There are more people hospitalized in the United States right now with COVID-19 than there are residents of the city of Portland. Over the past week in the United States, there's been an average of over 160,000 cases per day, representing an increase of 73% from that same average just 2 weeks ago. As of this morning, more than 11,800,000 people in the United States have been infected with COVID-19, and at least 252,300 people have died. These numbers are staggering, and as we'll talk about in a bit, numbers that we fear may continue to increase. As of right now, there are a total of 9,958 individuals in Maine who have been diagnosed with COVID-19, an increase of 224 new cases since yesterday alone. Of those, 8,933 are confirmed cases and 1,025 are probable cases. 173 individuals have died with COVID-19, and cumulatively, 628 have been hospitalized. Right now, today, in the state of Maine, 90 people are hospitalized with COVID-19. 49 of those 90 are in the intensive care unit. That's 14 more people in the ICU just since yesterday. 12 people overall are on ventilators, the same number as it was yesterday. And 7,590 individuals have recovered, an increase of 187 recoveries. Among our 9,958 individuals, 1,457 are healthcare workers, an increase of 21 new cases among healthcare workers just since yesterday alone. I'd like to take a second to talk about the outbreak investigations that Maine CDC has opened since the last time I spoke with you on Wednesday. This is a long list, and it's indicative of where we are with respect to COVID-19 across the state. Yesterday, Thursday, Maine CDC opened 11 outbreak investigations. Those are at the Beckett House in Belgrade with 4 cases, Callis Elementary School with 4 cases, Carville Middle School with 3, the Church of Faith in Skowhegan with 3 cases, the Eric Knowlton School with 3 cases, the Hibbard Nursing Home in Dover Foxcroft with 3 cases, Lewiston Middle School also with 3, the Maine Department of Transportation Western Region facility in Wilton also with 3, Pinnacle Healthcare in Canton with 5 cases, the Rockland Marine Corporation with 6 cases, and York High School with 4 cases. Just so far today, Friday, Maine CDC has opened 9 investigations just today. One of which is at Bath Iron Works, where we are aware of a total of 10 cases. Another at Dielectric in Raymond, where there are 4 cases. At Good to Grow Childcare in Elliott with 3 cases. At the Southern Maine Healthcare Goodall Hospital Mental Health Unit construction site with 4 cases. The Green Central School, also with 4 cases. Marshwood High School in South Berwick with 3. Upper Kennebec High School in Bingham with 8 cases. The Volunteers of America facility with 3 cases. And Wyndham High School with 3 cases. Cumulatively, that is 20 new outbreak investigations since the last time we spoke. I'd like to make one quick observation about that list. There are a number of schools on that list, which may be something that is disconcerting. Schools, as we all know, are among the most essential elements of our communities. They play a vital role in every aspect of our lives. Thus far, as I discussed earlier in the week, we at the Maine CDC have not seen significant or sustained transmission within schools. And that's a good thing. But that may change as rates of community transmission increase. But the fact that it has been limited to date is not only just a good thing, it's also not an accident. It's a direct result of the work that school administrators, teachers, and staff have undertaken and continue to undertake. Long before this year's school year resumed, teachers and staff and administrators working with the Department of Education and the Maine CDC began preparing for a school year that would be like no other in recent memory. They did so under conditions where, frankly, there were more unknowns than there were knowns. But their planning, their preparation, and their dedication to in-classroom education are paying off. Because of that hard work, because of that planning and preparation, children in Maine are, to varying degrees, able to participate in classroom education. Not in every school, not in every county, not every week, not every day, but in many places for different periods of time. And that's important for children and for our communities. So I'd like to take a moment to thank those teachers and those staff for keeping children in Maine in classrooms as much as possible. Every teacher, every cafeteria worker, every person who cleans the floors, who opens the doors in the morning, who picks up the kids on their way to school and drops them back off in the afternoons. We all of us in Maine owe you a debt of gratitude for the work that you've done to help keep kids in classrooms as long as possible. I'd like to take a second now to talk about where we stand with respect to testing. Our 7-day test positivity rate in Maine has jumped upward again. It now stands at 2.90%, up from 2.66% yesterday. Our testing volume, however, remains at a high and robust value of right now 646 tests for every 100,000 people. Before I turn to questions from our colleagues in the media, I want to talk a little bit about where things stand right now. The world is so much different right now than it was just 1 year ago. Last year, around this time, I was working with one of our colleagues in the media, Beth Brogan, to talk about safe ways to cook your turkey and not introduce salmonella at the dinner table. But holiday safety means something much different this year than it did last year. Everything has changed. And as we've talked about, the world has turned upside down compared to where we were a year ago. We all know that the world's changed. But what's also different is the way in which COVID itself has changed just over the course of the pandemic. I'd like to take a second to talk about that. There's a certain stickiness in the way that the human brain perceives events. Our first impression of something is quite often the lasting impression of that same thing. And as a result of those lasting impressions, we often key our behaviors off of that initial anchoring perception. We've all experienced this. The initial understanding that we form about something is the norm. And even when the facts around that change, our brains have a tendency to explain those facts away as anomalies or noise. Frankly, that's just what it means to be human. But sometimes we have to recognize that the fundamentals of what we were initially presented with have changed, sometimes quite significantly. And this reminds me of my father. My dad moved to the United States in the early 1970s. He worked as a busboy at the now defunct Gold Coin restaurant in Chicago for a long time until he earned enough money to buy a used car. It was a gold Pontiac Ventura. He was so incredibly proud of that car. It was the first car he had ever owned. Now, you got to understand, my dad moved here from India, never owned a car, barely owned a bicycle. He knew nothing about cars. So his entire understanding of cars was forever informed by that very first purchase, what that very first car salesman told him about cars. And what that car salesman told him was, you got to change your oil every 3,000 miles without fail. And because that was the first thing my dad was taught to do with his used car, that's the thing he did forever and ever and ever. The thing is, as time went on, and cars got better, and engines got better, and engine oil got better, my dad couldn't appreciate that the world around him had changed. He couldn't appreciate that he didn't need to change his oil so frequently. He didn't appreciate that the fundamentals of cars had changed, and thus so could his behavior. He didn't realize he didn't need to change the oil every 3,000 miles. And so for years, decades, he resisted changing his behavior. And he did what all humans do. He used every mental trick in the book to justify not needing to change the way that his behaviors were. And that's because his entire perception of what it meant to have a car, a novel thing for him, something he had never encountered, his entire perception was colored by that initial understanding he formed with that very first used gold Pontiac Ventura. I feel like right now, we're in a similar position with respect to COVID. The fundamentals of the pandemic in Maine have changed. But many of us are still like my dad with that car, still thinking that what was true 20 years ago or even 8 months ago is still true today. And we're keying our behaviors off of that initial understanding, even though the fundamentals have changed. And sadly, in the current environment, in the face of a deadly pandemic, not updating our understanding of the pandemic and the way it has changed carries with it severe consequences. So what I'd like to do today is to help everyone update their understanding of the pandemic so that we can all update our behaviors. Let's talk for a moment about ways in which today's pandemic in Maine is fundamentally different from the pandemic that we started with back in March. For example, back in March, much of the transmission that we saw was a result of focal outbreaks, often driven by things like long-term care facilities. Today, much of the growth in new cases is driven by community transmission. Earlier in the outbreak, many of the cases we saw in the United States, as well as in Maine, were in urban areas. But today, the pandemic has changed. And it is not just an urban phenomenon, it is equally a rural phenomenon. Earlier in the pandemic, much of the growth in new cases was associated with large gatherings. But today, small gatherings are generating much of the force of transmission. Early in the pandemic, COVID-19 was associated as a phenomenon of populated states. Think of New York, think of Texas, think of Florida. But today, smaller states are seeing significant increases in cases. Think of North Dakota, think of Wyoming, and sadly, think of Maine. Earlier in the pandemic, it was predominantly older individuals who were affected. Today, the average age has dropped considerably, such that younger individuals are infected. Earlier in the pandemic, risk was associated with certain settings, but today, risk is everywhere. Earlier in the pandemic, much of the growth curve was linear. 10 cases led to 10 cases, led to 10 cases. Today, the growth curve is exponential. 10 cases leads to 30 cases, leads to 90 cases, so on and so forth. We were, for so many months, used to seeing COVID-19 as a severe phenomenon in other states, but now it is a phenomenon that is severe in our states. Earlier in the pandemic, what was for so many of us an abstract concept is now very real. We need today, as a state, to update our understanding so that we can update our behavior. If we don't do something different, nothing is going to change. We will stay on this trajectory of increasing cases, which each passing day will make it harder and harder to put a lid on things. Now, I understand that the relentless flow of new information has not slowed down one bit in 10 months. We've endeavored at the Maine CDC to make the best decisions we can based on the best available scientific information we have at the time. Now, from your perspective, it might feel like we keep shifting our guidelines. But to be completely candid with you, that is exactly what we should be doing. I'd much rather tell you that based on new evidence that has come out in the scientific literature, I'm shifting my guidance from A to B versus stubbornly sticking with guidance A simply in the name of being consistent. Imagine if your doctor did. Imagine if a loved one was recently diagnosed with cancer and you went to an oncologist and the oncologist said, you know what I don't like about the field of oncology and cancer medicine? It's how we keep shifting our guidelines all the time. And I want you to know, sir or ma'am, I don't change the way that I practice cancer medicine. I haven't changed a single thing since the day that I graduated from medical school 30 years ago, because consistency is what matters. You would run out the door as fast as possible. You should expect that the public health agency in your state follows the same current scientific information as your oncologist does. That's why guidelines for various activities, businesses, travelers, back to school, social gatherings, have all been shifting lately. And they will continue to do so, because that's what scientists do. We respond to the facts in front of us with the best data that we've got, and we get better at it every day. We do something different so that things can change. Now, our healthcare system is seeing significant increases in patients, Labs are working beyond capacity, all of which strains our ability to do case investigations and contact tracing in a timely manner. Hospitalizations are increasing. Indeed, there are more people in the hospital with COVID right now than there ever have been. And we're seeing more and different outbreaks across the state, as I mentioned a moment ago. And today, we're seeing 224 new people be affected. I know this may scare you. That is not my intention. I'm just laying it all out. I'm being transparent with you so you can appreciate the severity of what we are facing. We are at a critical turning point. Now, on our end, we're doing what we can, increasing lab capacity, training more case investigators, working with healthcare facilities, improving the way that we operate so that we can help get a lid on things. But these things take time. And right now, time is a luxury that none of us can afford. And so that's where you come in. Your actions matter, perhaps more than you realize, and almost certainly more than they ever have. We've talked about at length in these briefings over the last 10 months how the actions of one or two people going to a seemingly innocuous gathering can have ripple effects that affect hundreds of people. Now, for a second, think about the actions of not just one or two people, but 100,000 people, let alone 1 million people, and how that could affect the trajectory of where we go from here with respect to COVID. Now, many Maine people are already doing the things that we need them to do, hunkering down, changing their plans, keeping distance, wearing a mask. And for that, I thank you. We know you're tired. We're tired too. We haven't slowed from this relentless pace for 10 months. And the fact of the matter is, we're still here and we're not going anywhere. But we need your help today to see if we can change the trajectory of where COVID-19 in Maine is going. So with that, I'd like to turn things over to our colleagues in the media for today. And the first question goes to Charlie from the BDN.
Yep. Hi, Dr. Shah. Thank you. Can you tell me how close Maine's hospitals are at this point to reaching sort of their full capacity of admitted COVID patients? And also, are there any particular facilities that seem to be filling up at a faster rate?
Sure thing, Charlie. So let's first go through the numbers just really quickly. Right now, across the state, there are 92 ICU beds available. We also, I can go through some of the other numbers, but to answer your question, it varies. And it's not that there has been one facility that has been driving the increase, but that's largely because the dispersion of COVID-19 patients is now happening more uniformly across the state. Let me translate that a little bit. Previously in the pandemic, and I guess this is yet another way in which the current pandemic is different from the earlier pandemic. Earlier in the pandemic, many of the hospitalized patients, both in regular as well as ICU beds, were in 2 or 3 tertiary care facilities. But as the healthcare system has gotten more experience with treating COVID-19 patients, patients can be hospitalized closer to home in community facilities. This expands the number of beds that we have available, for example, in the ICU. It also means that 1 or 2 facilities are not carrying the weight of the bulk of hospitalized patients. So there really is a dispersion across the state.
Okay. And then related is, you've talked in the past about the sort of backup satellite facilities last spring that were under consideration in Bangor and Portland, and obviously those did not end up being needed. But do you have a sense if we're close to needing them now, and if not, like what would trigger that at least to be the case?
Sure. Charlie, let me start by saying several weeks ago, as we started seeing an increase in cases, and recognizing there would be an increase in hospitalizations. We dusted those plans off. We got them off the shelf and started reigniting the discussions that we had had previously with healthcare providers, hospitals, city officials about where we were in that planning process and what we may need to pick back up on. Fortunately, we have a significant amount, as I mentioned, a significant amount of headroom, extra space in the healthcare system, so that if additional individuals needed to be hospitalized or placed in intensive care, based on where we are right now, the system can accommodate them. But the system has fragility in it. The system depends on, for example, staff being healthy and able to take care of patients. So for that reason, we've dusted off those plans and re-immersed ourselves in those discussions. The process of setting up a field hospital of that nature is one that once we have started the process and given the green light to it, can be done not in a matter of weeks, but more in a matter of days. So it's not as if we need to have a multi-week run-up period, but we are keeping very close tabs on these hospitalization numbers. We are not today at the point where we've had to okay or green light standing up these so-called alternative care sites, but it's something that is sadly something we're talking about and discussing now with increasing frequency.
And can you just be any more specific about what sort of, capacity you would be looking at, or lack of capacity that, again, would get you to that green light?
Yeah, it's really a function of if we projected within the coming week to 2 weeks that we would be running out of ICU capacity or regular bed capacity, or let alone ventilators. Thankfully, on all of those fronts right now, we are in good stead, particularly on things like ventilators. But if we saw on the horizon, or if we heard from healthcare providers that staffing was becoming a bigger concern, for example, those are the times when we would start moving toward activating some of those plans, going from the planning process to the activation phase.
Okay, thank you.
I'm going to turn things over to Morgan at WABI.
Hi, Dr. Shah. Thank you for taking my questions today. My first question it's actually from a viewer who lives in Hancock County. She is 74, and she wanted to know if you thought that her plan was a good strategy. She says, if she should get sick, she's going to go to bed, isolate in the bedroom, let her spouse set food outside her door, and hope to recover at home, i.e. no hospital unless she becomes dire. This strategy is mostly to alleviate strain on local hospitals. Is this a good strategy? She's not sure if she should even get tested unless she is severely ill.
Let me start, Morgan, by just being very clear. I am not in a position to be giving out any sort of medical advice whatsoever in general or to particular individuals. That being said, I think this is something that your viewer, your listener should chat about with her healthcare provider. Because generally speaking, what we recommend and what I think all other healthcare providers would recommend is that if you're not feeling well, you seek medical assistance, particularly when we're talking about COVID. The reason I say that is that one of the unfortunate and insidious aspects of COVID is that individuals can deteriorate medically very quickly. Someone can go from being okay in the morning to feeling really under the weather at noon and being in dire straits by dinner time. So again, I am not in a position to provide any medical advice to any individual, but I would strongly recommend that anybody who is wondering how they should plan for the possibility of COVID, talk to their healthcare provider today rather than waiting until they've gotten sick.
And one more question. It is about Sandfield Rehab and Living Center in Heartland. We are hearing from numerous people that there are multiple cases there, almost 20 cases there. And I was wondering if that's anywhere on your radar.
Yep, I believe I discussed this the other day. Right now at Sandfield, we are aware of 27 total cases, 17 among residents and 10 among staff.
Thank you.
I'm going to one correction before I go to the next question. I indicated that there were 3 cases associated with the Maine DOT facility in Wilton. That was an error. There are a total of 5 cases associated with that facility. And I'm going to turn next to Eric Russell at the Press Herald.
Thank you, Dr. Shah. You talked a little bit about schools and saying that there's still no evidence or much evidence that transmission is happening in the schools themselves. How would you go about finding out whether or not that is happening? What are the mechanisms by which you can tell that it's happening in the schools versus happening with community transmission?
Great. So Eric, let me first start by noting that that could change. This is based on where we are today. And indeed, one of our operational goals is to keep it that way so that kids can remain in school. That is one of the goals we've got right now. So here's, one other quick little note, Eric. The findings in Maine were recently mirrored by a report that health and education authorities in Scotland released the day before yesterday about the Scottish experience with schools thus far. And I read the report with interest because of some similarities in geography and demography between Maine and Scotland, and they've had a similar experience in Scotland. So here's what is required in order to demonstrate transmission within a facility, and it comes down to a couple of things. It comes down to onset of symptoms and the nature of contact. So the way that we determine whether transmission has occurred in a facility or was a byproduct of other modes of transmission comes down to looking at, for example, where 2 individual cases or 3 or 4 individual cases were throughout the day. And did they meet that requisite cumulative 15 minutes of contact within 6 feet? The second thing that's really critical, though, is the chronology of their symptom onset dates. We have an extensive process that we go through where we match up when individuals had symptoms when they first started developing them. That's critical because one of the keys with COVID is not so much when you could infect other people, but it's when you may have been infected. So we look at those chains and we look at person A and person B to see if their symptom onset date squares with when we know that they were transmitting virus and whether those dates line up to when other people may have received the virus and started developing symptoms. Now, in some cases, not just looking at schools, but workplaces and such, we are able to nail down with a high degree of certainty that person A spread it to others. One of the things we have to exclude in order for that finding to hold true is that individuals didn't have contact outside of the workplace. They didn't. They weren't rooming together at a hotel or going to the bar together after work and potentially exposing others. So sometimes in school settings, we have to go one step beyond and ask whether those individual students were part of the same play group or things of that nature. So it's a very extensive process, but this is what case investigation, when I talk about case investigation, this is what case investigation entails. It's going upstream to figure out where people were exposed and in what chronology.
And if I could just follow up, since you mentioned case investigation, on Wednesday, your office announced that you were no longer going to be contact tracing probable cases, and you explained why that was happening, or not until they're confirmed with a test. It sounds like you want to jump in here in just a second, but
no, I'm keeping my mouth shut until keeping my mouth shut until you finish your question.
That felt a little like just a tacit acknowledgement that contact tracing statewide is becoming burdensome. And I know you've alluded to this a little bit in the past couple of weeks, that it's getting harder and harder to contact trace because the cases are going so high. And I wonder, if you can again update us on where we are with that and whether we're getting close to that ceiling that we talked about, or yeah.
Sure, Eric. I want to respectfully disagree with one aspect of your characterization, which is on the burdensome piece, but I'll get back to that in a moment. The reason I almost jumped in but held myself back was I want to distinguish case investigation from contact tracing. So the process that I outlined, for example, with schools, that's case investigation. Mm-hmm. Case investigation asks, where could you have gotten COVID from? Contact tracing asks, who could you have given it to? They are related, obviously, but from a process perspective, there are different processes in place to figure out where you got it from, that's transmission, versus who you gave it to, that's contact tracing. The change that we announced was in recognition of the fact that one of the ways that you could be a probable case of COVID-19, which I talk about, I announce, one of the ways that you could be a probable case of COVID-19 was to have been exposed to somebody with COVID and then develop any of the various symptoms associated with it. But as I talked about on Wednesday, as we go into colder months and other things like the common cold are circulating, what we were starting to see was a lot of people who had had some degree of exposure to COVID-19. And when our case investigators would work with them to figure out where they got it from and get them tested, an increasing percentage of them turned out to have rhinovirus, the common cold. So that's why we moved to what some other states have started moving to, which is to say, to be a probable case, you got to at least have a lab test from an antigen test to show that. But to be sure, Eric, part of that is in recognition, not just of a lower yield with those probables, given that everyone's got the cold now, but also that there are challenges coming, and we need to preserve public health resources for confirmed cases so we can really be vetting where they are getting it from and figuring out those questions like school transmission that I talked about. So that's what was going on there. Did not affect contact tracing, although to be candid, we're thinking about making changes there as well. But the change we made is on the case investigation side. I know that maybe sounds a little academic, but it's a big difference in how we go about it. In terms of the numbers, right now we've got approximately 135 individuals, maybe 140, but I'll check and get the exact tally, who are involved in case investigation and contact tracing. And we are training more and more of both case investigators and contact tracers. We're training them up very, very rapidly so that we can keep trying to keep tabs on things.
Thank you.
Mm-hmm. I'm going to turn now to Amy Brown at WERU.
Thank you, Dr. Shah. Just real quickly before my questions is just to follow up. The national 7-day positivity rate is 10% now. Is that correct?
I don't have it in front of me, Amy, but I can check on the US CDC website, but that is probably about the right ballpark.
Okay, and that was the number I think was yesterday or the day before.
Mm-hmm.
Anyone who listens to these briefings will hear your warnings and recommendations, but it's likely that the people who you really are trying to get them to are also not paying attention to the briefings. A listener asked us what's being done to target those individuals who are skeptical about science, and she wondered specifically, she wanted us to ask you whether or not the CDC is partnering at all with primary care providers to get them to do some education and outreach, or others in the community.
So first, Amy, don't like the word target. We don't target anybody. And I just want to be really clear. We're providing information for everybody. But we know that there are folks that to date still haven't seen COVID as the threat that we see it as. So we're working with a number of different folks. Some of them do include working with, for example, the Maine Medical Association, as well as healthcare providers who are very well trusted in their community. Some of it involves working with other well-known and well-trusted folks across Maine to talk about the risks or experiences that they've had with COVID. We've also been working with a production company to find well-known Maine people who may speak to a different audience than I typically speak to, or than Commissioner Rambrew or Governor Mills may speak to reach out to them. One that I'm particularly proud of is we recently worked with the artist Spose to put out a PSA, and Spose talked about the impact that COVID was having, not just on musicians, but on stagehands and the sound engineers, and how all of that is meaning that live music isn't what it was before. So there's a lot of other channels that we are pursuing to try to get the message out there around what COVID is and how serious it is. There's not just one outlet or one channel, it's many, many different channels.
Okay, great. And what is the final or latest case count associated with the Brooks Pentecostal outbreak?
The Brooks Pentecostal outbreak stands at 62 individuals.
And is that considered closed at this point?
I believe we did close that investigation this morning or yesterday. I'll check and find out.
Great, thank you.
I'm going to turn things over to Dustin at New England Cable News.
Hi, Dr. Shah. These are questions about the new 9 p.m. business closure mandate. First one, what was the rationale behind the time frame? Why have this until December 6th?
Sure. So, Dustin, where we wanted to start there, and I should have noted, we're joined this afternoon, particularly for questions of this nature, by Commissioner Heather Johnson, the Commissioner of Maine's DECD. So, Commissioner Johnson, thank you for popping on this afternoon. Dustin, I'll take that first one on the epidemiology. The rationale was that we wanted to at least go one incubation period. And as it turned out, at the end of that incubation period, being on a Friday, we extended it through the end of that weekend.
And then do you expect the curfew or the mandate to last beyond that point to extend past December 6th?
Just you noted it, but again, terminology, not a curfew. But in terms of where things go, I think that'll depend on the data. We haven't made any final decisions. This is, again, an iterative process. This is what science does. We take a look at the data, see where things go, and then evaluate from there. Commissioner Johnson, anything else on your end there?
No, nothing to add, Dr. Shah. Thank you.
Dustin, anything else on that?
Nope. Thanks.
Okay. All right. I'm going to turn it over to Ashley Blackford at WAGM.
Hi, Dr. Shah. I have two questions for you. We're hearing there are 4 cases at the University of Maine at Presque Isle of students that are in the dorms. Are you investigating that as a possible outbreak?
Ashley, I have also, or earlier this morning or late last night, was also made aware of those as well. As of right now, we have not opened an outbreak investigation there, but I think we're gathering some additional facts today.
Okay. And for the students there and kind of in universities, I guess, all over that are heading home, are you encouraging the students on campus, if they have gotten a test, to wait for the test results before they go home?
I think that's the best practice. Travel introduces the possibility of exposing others. And so after you know what your result is, it's a lot easier to travel with a certain degree of confidence, particularly if you're going back home, as many students are for the remainder of the year, and potentially interacting with grandparents, older relatives. So, knowing where you stand with respect to COVID before you initiate your journey is a good practice. It may not be feasible for each and every student, in which case the best thing to do is to try to remain in quarantine until you've got your negative test result, so you don't potentially affect the other family members. I'm going to turn things over to Evan Popp at the Maine Beacon.
Hi, Dr. Shah. Thank you. So I wanted to ask a little bit more about vaccine distribution. And you said when a COVID vaccine is approved, healthcare workers will be some of the first people in line. And I was hoping that you could go into a little bit more detail about that. Will there be any preference among healthcare workers? For instance, with the Pfizer vaccine, you noted that that's one where people would likely have to be brought to the vaccine. Does that mean that hospital workers would receive it first versus other healthcare workers, or what's your sense of that?
Yeah, that's a good question, Evan. So according to the National Academy of Science, Engineering, and Medicine, this was the expert group that was convened earlier in the summer to help states think through these issues. What they recognized is that even within their categorizations, phase 1A, 1B, there was still a lot of people and a high degree of variation. So what the National Academy recommended is that within each of those categorizations, the preference be given based on the degree of possible exposure to COVID-19. So for example, within healthcare workers, we're working with hospitals to refine this a bit more. But within that first category of healthcare workers, some healthcare workers have a higher likelihood of coming into contact with a COVID-19 patient. Those are the ones that we'll be looking to offer the vaccine to first. again, because they have a higher likelihood of coming into the contact with the vaccine. And then so on and so forth, kind of down a graduated scale throughout healthcare workers, focusing on those with the highest likelihood of exposure and then working downward from there.
Great. And my second question, I was just wondering if you have a sense of how long it might take to know the impact of Thanksgiving holiday on COVID numbers. Would that be kind of one incubation period after, or what's your sense of that?
Great, good, Evan. So I'll say two things. Yes, you're generally right about one incubation period. However, this is a situation where sadly we've got some data. I think, as I've mentioned, our neighbors to the north had their Thanksgiving celebration on October 12th. And sure enough, on or around late October, the 24th, 25th, 26th, cases in Canada started increasing. They were already increasing in Canada, but following about one incubation period or so after their Thanksgiving celebration, their inflection point took another sharp turn upward. So the incubation period itself for COVID-19 is 5 or 7 days, but by the time someone starts feeling symptoms, experiences them with enough severity, gets tested, goes to their doctor, gets the results, all in, it could be 12 to 14 days. And again, that's not just based on the model, but based squarely on the experience in Canada in the last 3 weeks.
Thank you.
I'm going to turn things over to Patty White at Maine Public.
Thanks, Dr. Shah. In terms of hospital capacity and when we may reach capacity, understanding that it's dependent on many factors, including staffing levels, what are the numbers in the models that you're looking at? I mean, is the hospitalization rate one of the indicators? And do you know what our hospitalization rate is now?
So I'll start with the first one. Hospitalization rate is one of them, Patty, but we actually, there's a bit more information to be gleaned from just the raw numbers of hospitalizations. But of course, the rate is important because if we see an acceleration in the number of hospitalizations to a point that a model suggests that we might exceed capacity, that's a sign for us. The models that I think have been the most predictive thus far of Maine's hospitalizations have been a series of models and frameworks developed by epidemiologists at Columbia University. And that's their models to date have, for me at least, proven to have the highest degree of accuracy and sensitivity. Maine is interesting in a good way because we've had few cases. But one of the things with models is that term sensitivity of the model. Some models, if there's a small deviation, 2 to 3 cases, for example, in some models that's interpreted as a 50% jump, but not really a 50% jump when you're talking about utilization. So the Columbia model has been one that I've looked to help take advantage of that. We can get you some of the background on that and some of the links, but I don't feel like I've answered your question appropriately. So let me turn it back over to you.
No, that was really helpful. I just wanted to know what were the indicators. And so that model from Columbia, and then you said the hospitalization rate. And I don't know if you know what that is, but if there are any other things that you're looking at, that would be good to know.
We can get you the hospitalization rate. We also take a look, going back to the staffing piece, at the place of hospitalization. This kind of, I think, goes back to Charlie's question. We're also in very frequent contact and communication. We have a staff person actually who's part of his job is to be in contact with hospitals every single day to try to get a sense of whether particular hospitals are becoming overwhelmed so that we can try to make adjustments from a staffing perspective, from a patient transfer perspective. So we're looking at those things at the granular level. If hospital X in a particular area of Maine has only Y number of ICU nurses, well, if a fraction of those ICU nurses comes down with COVID, that's a game changer. So those are the sort of really granular kind of ground level facts that we're trying to keep tabs on every single day. So it's partly about beds, but really also about the staffing and the geography of where patients are.
Thanks. Can I ask one other question about staffing?
Sure. Mm-hmm.
If there are staffing shortages, are you mostly looking at kind of shifting staff from one hospital to another? Or I know there's the Maine Response Program. Is there kind of a decent supply there that could be sent into hospitals if necessary?
So there's a couple of strategies when we start thinking about staffing shortages. One of them is working with hospitals, either geographically or on a system basis, to make resources available in places where they may be more needed. The corollary strategy is to not move the staff to the hospital, but move patients to the hospitals where the staff are. So that's more of a centralization model. Another strategy is the use of volunteers. Another strategy is to recognize that there may be staff in other parts of the hospital who may be deployed in ways that could be temporarily put on hold and then be repurposed or redeployed for COVID. That is a long way of saying potentially contemplating putting a hold on things like elective surgeries. That's a big step, though. And Maine did that previously, working with hospitals. And as I've spoken with cardiologists, neurologists, cardiothoracic surgeons, neurosurgeons, there are certain things you can put on hold in the neurosurgery and cardiac surgery world for a couple of days, but not many surgeries that you can put on hold for a couple of months. So even though that's an option, it's an undesirable one.
Okay, thank you.
I'm going to turn next to Rachel Mann at ABC 7. We'll come back to Rachel in a second and go to Rebecca Stefanski at News Center.
Hi, Dr. Shah. Bear with me here. I have a few questions, and they're kind of disparate. Are we seeing an increase in testing that may be related to people looking to gather for Thanksgiving? Perhaps they're asymptomatic, not exposed. Do we expect a backlog of testing after the long weekend? I mean, I guess it's hard to predict, but.
Yeah, so Rebecca, so let me say two things that seemingly point in different directions. The first is, as we've discussed on Wednesday, testing resources are strained. We've heard loud and clear from folks that they're finding it difficult to get tests. One thing that we've done just in the last 48 hours, 36 hours, is bring on more than 50 Walgreens locations that will offer the rapid point of care, so-called Binax test. But that test is for folks who have symptoms. You described individuals who don't have symptoms. And we haven't seen, so far as I can tell from the data, a significant spike in individuals who have no symptoms getting tested. Why do I say that? Because our positivity rate has continued to climb upward. It did have a small plateau for a couple days, but it's taken another jump. If there were a large number of asymptomatic, well people just wanting to get tested prior to, say, travel, one would have potentially expected a dip in the positivity rate, but instead we've seen an increase.
Okay. And
recognizing those things seem to point in different directions, I know. But again, more testing is coming online at places like Walgreens. But as a reminder, that testing option at Walgreens is for folks who have symptoms, not because we're trying to be restrictive, but that the test doesn't perform as well in people who don't have symptoms. It can lead to false negatives. So it's not that we want to be restrictive. It's just that the test itself really just does a lot better if you've got symptoms.
Sure. Okay. And my follow-up to this is, actually, as you were speaking, I thought of it, that are any other states asking us if we have extra testing supplies since we've done so well? Or are the states communicating in any way like that, sharing reagents or swabs or et cetera?
Rebecca, with respect to the sharing of reagents, there are discussions of that nature. But the thing with reagents is that even though back in March I used an analogy to baking, the thing with reagents is that they are highly specific to the protocol and procedure that exists at each lab. So a reagent that we utilize at our laboratory here in Augusta may not be able to be used at the lab in Vermont because they use a different type of test. So for that reason, there may be sharing going on. I don't know. But unless another laboratory used the exact same test with the exact instruments we do, sharing of reagents isn't something that's typically done just for that reason alone. Again, not because we're trying to be stingy. It's just It's got to be the exact same thing. With respect to swabs and transport media, we haven't received any requests, so we've got a robust supply of those, but we haven't received requests from other states, and I haven't heard from other states that have expressed concern about that particular resource in large fashion.
Okay, and now on another, thank you for that. On a slightly different topic, if you do know somebody that has tested positive for COVID and maybe they were in your home or your car, is there any special cleaning or disinfecting that you would recommend to people other than quarantining themselves and getting tested and taking all of those precautions? I know that there's been sort of a step back of touch surfaces to some degree. Yeah. And I'm sorry about that. They're putting plexiglass in our newsroom.
No, that's a question that comes up a lot, Rebecca. It's a really grisly situation, to be sure. And one of the things that we've learned about COVID since the beginning, I guess this is yet another thing to add to the list of how the pandemic is different today from earlier, is that surfaces and the likelihood of acquiring COVID from a surface is lower than what some folks feared it was back in March. That's a good thing. But to be sure, there's not a special solution or a special product. The US EPA on its website has a very long list of everyday household cleaning products that are effective at neutralizing the COVID virus. You can Google it, take a look at those, but it's the household names that everybody here knows. And what I would recommend for somebody who's been in the car or in a household with someone who later tested positive is to just use one of those solutions to wipe down surfaces, to make sure that anything that anyone may touch has been thoroughly wiped down. Thankfully, the situation with touch surfaces is not pandemonium like it was back then. And so just simple everyday household cleaning procedures are all that's needed.
Thank you very much, Dr. Shah.
Okay, I'm going to turn back to Rachel Mann. Okay, we'll go over to Allison Ross at WMTW.
Hi, Dr. Shah. Just two questions today. So I asked the governor's office this morning, and they directed me to you for this question regarding her implementation of this curfew for businesses at 9 p.m. We're getting some questions as to why 9 p.m., why not 8 or 10? So how will 9 p.m. stop the spread?
Okay, Commissioner Johnson, can I turn that one over to you?
Yeah, thank you, Dr. Shah. I'm not sure that 9 p.m. is a particular magic point. I think the goal and the intent of setting a time for businesses to close was to try to reduce that congregation. And as we all know, congregation, as it gets later in the evening, riskier behaviors become much more natural for all of us. And this is a period of time that we know people are home from college and trying to meet with old friends. And that's just a part of the behavior that happens on these weekends. And so having a time for businesses to close helps us all focus and protect that later time in the evening that might be a higher risk. We were really looking for, and Dr. Shah, feel free to weigh in on this, but we're really looking for a very targeted action that really looked at the specific challenge that we were seeing, or we were concerned about the high risk activity. And this was one that we thought kept as much business capacity as possible and preserved public health, and was that balance that we continue to always look for.
I completely concur, Commissioner Johnson. I think the word there is balance. We're looking for that balance, as we always are, to try to find the things that are the most effective from a public health perspective, and simultaneously ones that allow other activities. And for us, we thought that 9 p.m. struck that right balance.
Okay, great. And then Dr. Shah, NPR was reporting that you said, hypothetically, Maine would be ready to distribute a vaccine by next week. Of course, one has to be approved, a lot that goes into it. So how would that be possible? Or do we have enough really in place that if one was ready right now, we could be distributing it next week?
The answer there, Allison, is yes. But I want to be, I'll go into that a bit more. As we sort of mentioned with Evan, the first groups of individuals and recipients of this vaccine will be healthcare systems for use in their highest risk employees. The vaccine that, and for everyone's awareness, The Pfizer just a few hours ago submitted its emergency use authorization request to the US FDA. We do not know if or when, if at all, the US FDA will approve that, authorize that. But that first set of vaccines that comes to Maine will not be those for the general population. They will be for a very small group of exposed healthcare workers, potentially exposed. So that's why I felt that we would be ready for that. As we think about more general vaccination at a community level, at a statewide level, that unfortunately is many months away still. All the more reason I ask everyone again, don't let your guard down in the interim.
Thank you.
Rachel Mann, are you on? Okay, well, to round us out for the evening, afternoon, I'm going to go to Patrick Whittle.
Okay, thank you very much. Two things. There appears to be a outbreak at Bath Iron Works, which I believe you touched on earlier. I was wondering if there's anything more to be said about that, given that BIW has had outbreaks earlier in the pandemic as well. And also on the subject of vaccines, there seems to be some confusion out there about whether or not, when these become available, if people can if it's a 2-shot series, whether or not people can mix and match them, or whether you have to get whether the second one has to be the same as the first one, or whether it's something more similar to some of the others that are available where that's less critically important. And I would love it if you could sort of clear that up.
Yep, you bet. I'll start with Bath Iron Works, Patrick. You're right, we're currently at 10 cases there. We have been working with them and meeting with them. I think the key that we are focusing on and assisting them with is offering more and different types of testing for employees there. Previously, we had worked with a local healthcare provider. We're working again to see whether that type of system could be stood up again as well. But right now, for where we are, sort of first 12 or 15 hours into the outbreak, our primary aim is to try to get as many individuals who could have been exposed as part of this outbreak to make sure they can get testing. So that's where we're at. There will certainly be more updates, but we've been in frequent conversation with Bath Iron Works to date. With respect to the vaccine, you're right, that is a question that comes up a lot. The answer is that mixing and matching of one vaccine for the first dose and then another one for the second dose is not something that will work. At least based on everything we've seen in the data, both the first and the second dose need to be of the exact same vaccine. So if you start down the path with the Pfizer vaccine, that's got to be the same one a couple weeks later. If subsequent vaccines are approved or authorized, based on what I've been briefed out on, that same process will hold. This is important though, because it means that folks will have to know which vaccine they got first. And there will have to be systems in place so that we can help folks keep tabs on those things. So if you got your first dose of a vaccine in another state, and then you happen to be in Maine and it's time for your second dose, we need to make sure that we can align all of that. That's one reason states are working right now to share as much of this data as possible so we don't put up barriers to people getting fully vaccinated.